Good morning, and thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the login information can be found in the chat feature on the bottom of your screen. If you have any issues with this webinar or the CME login, please send me, Julie Hawkins, an email or drop a note via the chat feature. This morning, we're pleased to welcome Dr. Sadigh, who's an assistant professor in the Department of Radiology and Imaging Sciences at Emory University School of Medicine. Her major clinical interests include imaging of the brain and spine, particularly brain neoplasms and white matter diseases. She received her medical degree from Tehran University of Medical Sciences and her residency in diagnostic radiology, her fellowship in neuroradiology at Emory University School of Medicine. Her research interests include patient preferences, risk communication, informed decision-making, comparative effectiveness, meta-analysis, and systematic reviews. More recently, her work has centered on appropriate utilization of imaging tests, cost of medical imaging, healthcare price transparency, and financial toxicity. Her work in these areas has served to identify current gaps in patient-centered healthcare delivery. Welcome, Dr. Sadigh.
Thank you very much, Julie, for the kind introduction, and it's an honor to be here. So as Julie mentioned, I'm gonna today talk about financial toxicity, a health equity issue. And I know we had a grand round speaker 2 weeks ago covering similar topics. So my talk, I tried to make it complementary to what has already been discussed. These are my research supports in terms of the disclosure. So let's start with the social determinants of health. I mean, all of you guys know that these are conditions in the environment in which people are born, they live, they learn, they work. And by these conditions, we mean the social, economic, and physical conditions. And they can affect patients' outcome. I really like this social determinants of health conceptual framework. And as you see, our society interacts under paradigms of race, economic status, gender, and sexual orientation, which result in social and upstream social inequities. And then when these are taken to public institutions, these paradigms frame policies and practices and programs and result in institutional inequities. And then these upstream inequities can define the living condition that a patient lives in and then results in downstream behaviors and health outcomes. So now let's talk about financial toxicity. So financial toxicity, as again, like was discussed 2 weeks ago, are conditions that are arising from out-of-pocket medical expenses and decreases in income because someone that has a health condition is unable to work during or following their treatment. And based on the conceptual models, it has 3 main domains. One of the main domains is something what we call material condition. Material conditions include things such as medical debt, or a patient sells their home or refinance their home because they can't afford their medication. They use their saving or retirement account. They're gonna have an income loss. In the worst case scenario, they declare personal bankruptcy just because they wanna save money to be able to afford their care. And if you think about all the 3 domains that we're talking about, material condition is actually one of the domains that is going to be affected earlier. Patients usually sacrifice material conditions, go into medical debt before showing care non-adherence. The second domain is psychosocial domain. So this is basically subjective distress to increases in household expenses, what we call financial worry. A patient gets worried because they can't afford it. And this can be either proportional or disproportional to the cost of treatment or patient's baseline resources. And then the last domain is behavioral domain. These are coping behaviors that patients adopt to manage their medical care while experiencing that increased household expenses. And what do we mean by that? Patients become non-adherent to medication because of the cost. They delay refilling their medication. They take their medication every other day instead of every day to have it for a longer period of time. They stop taking their medication. They become non-adherent to imaging. They don't show up to their imaging appointment. They delay or miss their physician visits. And this is basically going to be affected usually towards the later aspects of the financial hardship, because obviously patients do all these to be able to afford that care. So how do we measure financial toxicity? There are different measures out there. You look at the studies, they measure it differently, but the main ones are, most of the measures are patient reported. Obviously, for financial worry, I mean, it's going to be a patient-reported survey. There is a validated survey called COST survey. It has 12 items, and you can assess that by asking patient how much their anxiety or worry is in terms of managing their finances and being able to pay for their care. For the material condition and the care non-adherence, also there are a lot of patient-reported surveys out there. And the reason is that, I mean, even like for care non-adherence, you want to see that care non-adherence is because of the cost. So you want to have more of a survey. But you can, the fact is that you can measure material condition and the care non-adherence objectively as well. For a material condition, you can use credit score and see how has been the effect of patients' cancer diagnosis or any health condition. We're going to talk about that on their credit score and whether they needed again to declare bankruptcy, they needed to take loans and those types of stuff. And for the care non-adherence, you can look at EMR and you can look at the rates of no-shows. But the only problem is that whenever there's a no-show in EMR, you don't know whether that no-show or that non-adherence was because of the cost or was it because of other reasons. So that's why that you want to always complement it with a patient-reported measure. But now let's talk about the scope of the disease. How bad is financial hardship? Again, studies vary because the way that people measure financial hardship varies in different studies. But in general, to give you an idea, 1 in every 10 Americans reported financial hardship in 2015. Around 2/3 of all bankruptcies filed in the United States are tied to medical expenses. This is a study, it was a SWOG study done by Veena Shankram from UW, and they looked at only material financial hardship in metastatic colorectal cancer. It was a longitudinal observational study. They measured material financial hardship at enrollment and over a period of time, about 12 months. And the numbers they got was around 3 months, patients with metastatic colorectal cancer were reporting 24% material financial hardship. And this number increased over 12 months to 71%, which is a pretty, extensive number. Again, like it shows how what is the effect of this cancer treatment, and cancer diagnosis on patients' material financial hardship. This is a study we did actually here at Winship a couple of years ago. We recruited 100 cancer patients, just surveyed them. And these were both new and established patients. 20% of them reported care non-adherence because of treatment expenses. Around 15% of them report that they delay filling of their prescription because they can't afford it. 4% of them were not showing up to their imaging because they couldn't afford it. And 12% were skipping office visits. Other studies, like in other settings, have shown, for example, this was a study based on SEER registry. These were, again, colorectal cancer survivors. And they showed 25% of their participants were unable to cover the cost of medical visits. And those who had actually this treatment-related financial hardship were 2 times more likely to be non-adherent to their surveillance colonoscopy compared to the patients who did not report financial hardship. But the issue of financial toxicity is not only limited to cancer. Yes, it was initially defined in oncology just because the oncology medications are super expensive. But since then, a lot of other diseases have, researchers have looked at the financial toxicity in a lot of other health conditions and saw that this is an issue that can happen with any health condition. This was a national survey of around 8,900 patients with diabetes. And they showed these patients report 55% cost-related care non-adherence because, again, they can't afford their diabetes medications. And this was compared to 21% who did not have any diabetes. We did a study here at Emory Brain Health Center on multiple sclerosis patients. Again, an observational longitudinal study, same as the Veena Shankram study in colorectal cancer that I showed you guys earlier. And we looked both at the cost-related care non-adherence and material financial hardship. And similar results. You see patients, MS patients at baseline, 1 out of 3 report they can't afford their care and they have care non-adherence. And then at 12 months, this number become 1 every 2, pretty significant number. And same deal with material hardship. Again, material hardship, you're going to see higher percentages, like 61% at baseline and 76% at 12 months, just because, patients sacrifice material conditions sooner than care non-adherence. And in this study, we actually saw that the degree of financial hardship actually correlates with patients' quality of life. This is another study just to confirm that, again, this condition of financial toxicity can extend to non-catastrophic health visit. Imaging is a pretty, compared to, again, cancer diagnosis, those expensive medication is a pretty non-catastrophic health visit. We did this study at the University of Michigan. We, again, surveyed 670 patients just were sitting in outpatient radiology waiting rooms. Obviously, they're coming from different background and health conditions. 15% of them endorsed that they have at least one episode of care non-adherence in the last 3 months. 4% of them were declining their diagnostic test because they couldn't afford it. 8% of them were delaying filling their prescription, and so on. Another study from an imaging perspective, all of you guys are familiar with the secondary interpretation of imaging. Your cancer patients get their imaging in another facility. For any reason, it can be more convenient for them. It's closer to their home. It might be even cheaper. And then they bring their disc or CD to you guys, and you guys submit it for a secondary interpretation from a radiologist perspective. So these patients, obviously, for that scan that was interpreted somewhere else, already received the bill. And radiology bills are, you're going to receive a bill for the for technical component or for the scanner time, and you're going to receive for a bill for the professional component, which is the radiologist time. So these patients already received those two bills. Then that CD is submitted here for a secondary interpretation, and patient going to receive a third bill from Emory for this secondary interpretation of financial their exam for the professional component. We actually looked at 7,000 secondary interpretations that are done at Emory and looked at what was the bills that were sent to the patients, how much patients ended up paying of that bill. The mean patient bill liability was around $27. If you think about it, it's very cheap. Actually, it's not going to cost that much. But despite that, of the patients that received that bill, the mean patient out-of-pockets, like how much patients end up paying back, was $14. So around 47% of patients overall received that bill, and only 17% of them actually paid the bill. Again, you see that although this sounds very cheap exam, but again, how much is the extent of financial toxicity for a very, very simple examination, which is not that much of an expense to a patient. So the issue of financial toxicity can even seen with preventive care. You don't need to be sick to have financial toxicity. You can just be a normal person going for your preventive examination. Obviously, screening mammography is covered by majority of insurances now, but a lot of older Affordable Care Act insurance, there are some of them that still don't cover screening mammography. And this study published in JACR showed that for every $100 that there is an increase in the out-of-pocket cost that you pay for your baseline mammography, the likelihood that that patient comes back in the next 12 to 24 months to get that second mammography, screening mammography, decreases by 1.9 points. Again, screening mammography can have false positive. 10% of the cases you're going to have false positive. And if you have a false positive, you need to do a diagnostic mammography, you need to do a diagnostic ultrasound. And although your insurance covers your screening portion, they don't cover the diagnostic portion. You still need to pay out-of-pocket costs. That same study showed that if a patient is paying out-of-pocket costs for the downstream diagnostic tests that come after a positive screening exam, the chances they come back in the next 12 to 24 months for their screening mammography decreases by 2.7 times. Again, show how extensive this financial toxicity is. The fact is that financial toxicity is not only affect those three domains that I talked, but it can affect more distal health outcomes. I already told you guys it can affect quality of life, and there are a lot of other studies confirming the same finding. It can actually affect patient symptom burden. Studies have shown it can affect survival as well. So again, a pretty important issue that can affect the outcomes. And it's not only affecting patients, it actually affects the family as a whole. That same study we did a couple of years ago here at Winship, we recruited both cancer patients and their caregivers. These were informal caregivers identified by the patients. And we found that 57% of these caregivers also report financial hardship. And I mean, obviously the degree of this financial hardship for caregiver and cancer patients were correlating with each other. So again, this shows how much can be the effect of this financial toxicity from the patient on their caregiver. It's going to affect the caregiver quality of life. It's going to even affect the caregiver adherence to their own health visits. So with all these that we talked about, so financial toxicity is really a health equity issue. So diagnosis of a chronic illness, doesn't need to be cancer, any illness, can have significant financial impact on patients and their family. Obviously, if you have insurance, your situation might be better. Insurance is going to reduce your cost, but it does not guarantee that you're going to have access to the highest quality of care. And it does not eliminate the risk of depleting your household financial resources. You can still have insurance and you can still be at risk of financial hardship. Obviously, for patients who are uninsured, the financial impacts are much more devastating and their health outcomes going to be poorer. Going back to this conceptual framework that we talked about, the direct, the indirect costs of navigating a healthcare, and by indirect, I mean caregiver time, patient time, transportation, all the other stuff, it all exists in a socioeconomic context. And so it should be managed alongside other household expenses. So if a patient coming from a lower socioeconomic status, they are more at risk of an upstream social inequities, the chances that they're going to be affected by this financial hardship and have high rates of downstream worse health outcomes is going to be higher. Another example of this is biomarker testing. You guys are familiar with biomarker testing becoming very popular for the choice of the targeted therapy. But it's not covered by all insurance. CMS actually recently issued a national coverage determination for next generation sequencing, so that these multi-panel genes biomarker testings can be covered by CMS. But the fact is that commercial insurance, not all of them follow CMS, although most of them now are kind of converging to have the same coverage, but there are still some commercial payers that don't pay for the biomarker testing. And Medicaid also is not bound by Medicare national coverage determination. So again, you see that how much this variability in coverage, in addition to the out-of-pocket costs that patient can incur from the biomarker testing, can increase the disparity gap that we have in terms of who can get the test, who cannot get the test, who can benefit from that targeted therapy, and who cannot. And although recently there are 3 states like Illinois and Louisiana and California, they have passed legislations that Medicare and Medicaid and state-funded insurance also covers, but there are a lot of more work there, a lot of other states that needs to go that pathway. So we talked about financial hardship is a health equity issue, but let's see what are the predictors. If financial hardship is a health equity issue, it is expected that the social determinants of health are gonna be the predictor of financial hardship. They are the factors that are associated with financial hardship. And it's true, studies have shown that insurance can affect financial hardship, the income, the family household income that patient have can affect their financial hardship, the neighborhood that they live can affect the financial hardship. And there are some studies actually showing also there is some racial and ethnic disparities, which I have more words on that because there are newer study, which I'm going to go over aside from this, for one slide, that's showing that a lot of health disparities that we attribute to race is not actually race. There are newer models showing that it's other factors, such as the neighborhoods that patients live in, such as the other structural inequities, such as the stressors that patients are exposed to that are actually resulting in those poorer health outcomes. But aside from these social determinants of health, there are some other factors, such as patient's age, what is the stage of the disease, how much self-efficacy a patient have that can affect financial hardship. But for one slide, I just want to go back about that interaction of the race and the neighborhood. deprivation. I mean, there are a lot of studies out there showing patients who are coming from a disadvantaged neighborhood going to have poor health outcomes. And these poor health outcomes range from they can have higher risks of diabetes and cardiovascular disease, higher utilization of health services, and they're going to have higher mortality. And this higher mortality has been evaluated in different cancers, head and neck, prostate, lung, and so on. But the interaction between the race and the neighborhood is something that is newly being evaluated. This study we published in Cancer recently, it was a secondary analysis of the Taylor-Rex data. For those of you guys not familiar, Taylor-Rex is a pivotal breast cancer trial that was funded by NCI, coordinated by ACOG-ACRIN, and they recruited around 10,000 patients from US and 5 or 6 other countries. The original Taylor-Rex trial goal was that in early breast cancer patients, should there be, what is the difference in survival among patients who are receiving only endocrine therapy versus those who are receiving endocrine therapy plus chemotherapy. And the arm assignment was based on an Oncogyne type recurrence score. And the original trial showed that there's no difference between the two arms. But there were other studies coming from that same database that there is racial disparities in terms of health outcomes. There's a specific a study published by Kathy Albane at JNCI looking at Black patients who are Black women were worse overall survival compared to the white women. And but those models were not taking into account these structural inequities that I'm talking about, like neighborhood. We did a similar study on those using that same Taylor-Rex data, looked at the early discontinuation rate of endocrine therapy. And in our model, in addition to patients' insurance and their demographics and clinical characteristics, we also included the neighborhood deprivation as an indicator of structural inequity. And I mean, our results showed, yes, patients again living with in lowest in highest deprived neighborhoods going to have higher rates of early discontinuation of their endocrine therapy. But the interesting result, which was opposite of whatever is published in the literature, was that actually Black women, when you adjust for the neighborhood, when you control for the neighborhood deprivation, were having a lower rates of early discontinuation of endocrine therapy, meaning that they were actually staying on that therapy for a longer time. They had higher persistence. And this result was totally opposite to whatever is reported, again, showing how these newer models gonna resolve that issue, that a lot of things that we attribute to race, it's not race, it's other structural inequity that results in worse outcomes. As a result of that study that published in Cancer, we actually did another study to look at a model that looks at race with neighborhood deprivation index, with early discontinuation of endocrine therapy in the model and its effect on the survival. Actually, the study is accepted in JAMA Oncology and the results are embargo. It's going to come out February 17th, but the results are interesting. But going back to our financial toxicity discussion, again, I mean, race has been shown as a predictor of financial toxicity, but we need more work. I mean, maybe it's not race. Maybe, again, it's access to healthcare, it's neighborhood, it's all other factors that are affecting financial toxicity. So from now on, I want to change gear in terms of like, what should we do? What are the interventions? And again, 2 weeks ago, when Dr. Kara gave her ground round, she talked about some of the interventions. She talks about financial health literacy, improving financial health literacy. And I'm here only going to focus on 2 of these interventions that has been the focus of my research. One is the out-of-pocket cost communication, and one is financial navigation. But let's first start with out-of-pocket cost communication. How can this be an intervention to mitigate financial hardship? So obviously, a lot of patients in the recent years with the surprise bills and sticker shocks that they receive are interested in knowing prices before receipt of medical services. But from a physician perspective or stakeholder perspective, this is kind of like an impossible thing because, first of all, physician says that The short patient visits that we have should be focused on patient management. I have only 15 minutes, 20 minutes to talk to this patient. I don't have time to talk about the cost. The other issue that has been raised by stakeholders is that even if the physician have a time to talk about the cost, they don't have access to the patient-specific out-of-pocket cost at the time that they are offering the treatment. And that's another issue because everyone out-of-pocket cost is individualized based on the type of insurance they have, based on how much deductible they have used, what is their maximum out-of-pocket cost, and so on. Also, there are some providers that worry that maybe disclosure of a high out-of-pocket cost before the treatment may backfire and actually may induce more financial worry and more non-adherence. So we don't know the effect of it. And in fact, yes, we don't know, but there are a lot of hypotheses that maybe talking about out-of-pocket cost is not a bad thing. There's this graph about level of arousal and performance. And it shows that if someone have low level of arousal, going to have low performance. If someone have high level of arousal, going to have high performance. But at an optimum level, you actually are going to have, at the medium level of arousal, you're going to actually have the optimum level of performance. So if you think about talking about out-of-pocket costs, maybe talking about out-of-pocket costs is not going to give you a lot of anxiety. It may give you a little bit anxiety, just enough for you to think about it, to plan for it, to have a shared decision making, and like in terms of like what is the best options, and maybe it actually improves your financial response. So this is the theory that a lot of people that are pro this approach are like backing it. Again, there's no randomized controlled trial looking at the effect of talking about out-of-pocket cost and its impact on financial hardship, its impact on care non-adherence, and so on. There are a few cross-sectional studies. And again, as you guys know, cross-sectional study does not show any causal effects, it just shows correlation. This cross-sectional study by Yusuf Zafar from Duke showed that there was a survey of 300 cancer patients, no intervention involved. Some of these patients, ended up talking about their costs with their physicians. Some of them ended up not talking about the cost with their physicians. And they showed that actually patients who talk about the cost are going to end up having lower out-of-pocket costs, which is great. Great. We wanted them to have lower out-of-pocket costs. But they also showed that the patients who talk about the cost are going to have higher medication non-adherence. That's not so great. But again, this study was not showing any causal. We don't know that it was the talking about the cost that result in medication non-adherence. Maybe the patients that actually talk about the cost are the same patients that are at high risk of financial hardship. They're at so much high risk of financial hardship that they're going to have care non-adherence anyway. And because they are at high risk, they are the people that are interested in knowing what the cost is and what type of bill they are receiving. And they are the people that are going to initiate that conversation with their physicians. To prove this, there was another study that came out. They use a nationally representative cancer survivorship data. And again, no intervention involved. It was a cross-sectional study. Some patients talk about the cost with their physicians on their own. Some patients didn't. This study again showed the people who talk about the cost going to end up having lower out-of-pocket costs. Again, great. But they showed that this reduction in out-of-pocket costs was not associated with receipt of appropriate cancer care, meaning that they were getting their necessary and appropriate cancer care. That reduction was because of they were not doing now some of the care that were unnecessary or there were doubt on them. Again, it kind of reinforced that process of shared and informed decision-making. Now they were talking about what type of the care I really need to do and is appropriate for my cancer. What is the care that I can bait of and not getting it? And that's this study, that was like how they ended up reducing their out-of-pocket costs. But believe it or not, regardless of which team you are, you want to talk about out-of-pocket costs or you don't want to talk about out-of-pocket costs, CMS recently mandated price transparency rule, effective January of 2021. So it's now like even more than a year. And based on this rule, hospitals must post their gross and their per specific negotiated rates online. And this should be in a master file. And they should also post same prices for 300 shoppable services in a consumer-friendly format. 70 of these 300 shoppable services are already determined by CMS. The other can be determined by the hospital. And also, it's expected by January 2023, health plans offer an online price transparency tool to allow customers to see their personalized estimates of out-of-pocket costs for 500 shoppable services. So again, great. I mean, it's a good rule. Should go. I mean, it's a very patient-centric rule. But there are a lot of problems so far with this rule. Let's start with the basic one, compliance with this price transparency rule. This study by Fumiko Chino in JAMA Oncology showed that in August, which was around 7 months after this rule became mandated, only 1/5 of NCI designated cancer centers were compliant with the CMS rule. And there are a lot of other studies coming, in different settings, not necessarily cancer, showing the same thing. We actually did recently a study on imaging. It's Impress in JACR, and it showed that same, we did our analysis in September, 50% were non-compliant in terms of showing the price for the imaging. Before, CMS had this rule that if a hospital is non-compliant, so we're going to penalize that hospital around $300. So after these studies came out, they actually just recently increased their penalty to $5,500. So we don't know if this increased penalty going to have effect on compliance or not. We hope so, but that was an action they took. And another interesting thing in our study on imaging that we found was actually the hospitals that were more compliant with the price transparency mandate were the hospitals that had higher consumer ratings, whether it was on Medicare website, whether it was their Google online review, emphasizing that hospitals that are patient-centric and have already a patient-centric approach are the ones that are going to comply more with this price transparency rule, which is also a patient-centric approach. But apart from compliance, I told you there are a lot of problems with this rule. First of all, let's just talk about accuracy. So obviously, the current mandate only says that you need to post your gross and payer-specific negotiated prices, which is so far different than the out-of-pocket costs. I mean, the out-of-pocket costs of the patients can be totally different based on the insurance that they have. But obviously, despite that, there are a lot of hospitals that when they launch their price estimator tool, they give you an option that you put your insurance information and actually it's going to give you an out-of-pocket cost. Emory is one of them. If you look their price estimator tool website, it's a pretty nice website. You put your insurance, it gives you what's the cost for your service that you're choosing and what your out-of-pocket cost is. But despite that, most of these websites only show the out-of-pocket cost for single insurance. If someone has a secondary insurance, there's no way they can get an out-of-pocket cost. I mean, the price that they're going to get is wrong. I mean, it's not going to, because it doesn't take into account their secondary insurance. If someone, the other problem with this is that, you expect a patient go find this price, because the price estimator tools are online. But a lot of patients may not know the name of the service. Again, in that study that we did on the lumbar spine, lumbar spine on these different MRI on these different websites is named differently. Some people call it lower spinal canal MRI. Some call it lumbar spine MRI. Some call it back MRI. So, and again, it all depends how much is the health literacy or technical literacy of your patient is being able to know exactly what is ordered with them and go find that service and find the price of that service. And then one other problem again with these is that a lot of services, and such as radiology, pathology, anesthesiology, there are two different bills that patients receive. I told you guys the example of radiologies. There is going to be a technical fee for the scanner time, which is owned by hospital, and there's going to be a professional fee by radiology. And a lot of places, actually, the radiologists are not employed by the hospital. They are like a contractor for the hospital. So when a hospital put their price transparency tool out there and they quote the price, they only quote the price for the part that they are responsible, which is the technical fee. So patients still going to receive a second bill on the professional fee. That's not included as part of that code. Again, another problem that how inaccurate these estimator tools are at the moment. And this study just recently published in JAMA Open exactly discussed this issue of multiple claims that I talked about. Mikhail Horny is a health economist here at Emory, and he touched base that a large portion of patients' bills actually coming from these independent services, providers that are not employed by the hospital, and how discordant it is that the price transparency tools that are showing the hospital bills versus the bill that patient gonna end up from both hospital and professional components. The other issue with these price estimator tools is access. This study in JAMA, it was an old study, 2016. Obviously, the mandate was not there yet, but there were some health insurance that were offering price estimator tools to their patients. And the study showed that of patients who have access to these estimator tools, actually 10% of them only using them. And a lot of challenges there. A lot of patients may not know the tool exists. A lot of patients are not accustomed actually to do price shopping for their providers. A lot of patients are not finding this information compelling or user-friendly. There was a recent article in Wall Street Journal, and it showed that after the price transparency tool mandate came, and obviously a lot of hospitals wanted to be compliant, despite they wanted to be compliant, they were not interested in that. So a lot of them generated codes so that when you search for a price estimator tool for their hospital, it's not coming up in Google as top choices. And it's going to be buried under 100 pages and 100 clicks till you can get to that price estimator tool. Other problems with these estimator tools is missing quality information. If you don't have a quality information as part of an estimator tool, then all patients gonna assume that like all of these places gonna have same quality. So I'm gonna go for the cheaper. And the fact is that also the other side is not correct. A high cost does not mean high quality. A low cost does not mean low quality. The correlation between cost and quality is not known. So if you want to have such a device, such an estimator tool out there, so you better include what the quality for each of these hospitals that you're showing with their prices are and what the price are, and let the patient make that informed decision making. We actually recently, this article of us came online this Monday in JACR. We did a conjoint analysis to look at how patients weigh cost versus quality. And we found that when there is a mild health condition, such as mild back pain, they don't care. Cost and quality might be the same. But if you think about the severe health condition, a lot of patients are willing to pay extra for extra money for extra gain in quality. And it makes sense. Again, like if someone has headache, if someone have back pain, yeah, just go get your imaging in a cheaper place. Everyone should be able to manage that. You don't need a good scanner. You don't need a subspecialized radiologist for that. But if you have cancer, like you want to have, that imaging in a high quality place, like a subspecialized radiologist read it, and hence going back to our discussion on secondary interpretation, that's why a lot of you guys even submit those images for the secondary interpretation here at Emory. And then the last part of this out-of-pocket cost communication is the delivery part. Again, who is supposed to discuss the cost? Routine patient-physician communication is recommended because you want to have an engagement in shared decision-making. But as we talked about, physicians concerned, our encounters are too short to talk about cost. We want to talk about patient. And some patients actually have concern that, yes, we don't want the physician be the one talking about the cost because it may jeopardize the chance of receiving best treatment. How about like someone else from that office, a nurse, a staff, a personnel talk about the cost after that meeting with the physician? So there are a lot of studies that needs to be done in this area to discuss this. But, and I think that the out-of-pocket costs I'm gonna go over it and combine it with financial navigation later, gonna have an impact on mitigating financial hardship, but there are a lot of work that still needs to be done. But let's move on to financial navigation. So financial navigation is also suggested as a way to mitigate financial hardship. Again, no randomized control trial has been done. All the studies are more cross-sectional studies or pilot studies. This study, again, by Veena Shankaran from UW showed that there were 11,000 new cancer patients. They received financial navigation between 2012 to 2016. 32% of them were qualified for financial assistance. And just to give you an idea of what financial navigation is, it's just basically a financial counseling approach. You talk with the patient how we can optimize your insurance. You need to be enrolled in Medicare, Medicaid or Medicare, let's enroll you. You need to change your insurance to a different deductible plan, let's do that. You're going to talk with the patients, what are the financial assistance programs that are available, and you enroll them. in those. And you basically discuss any cost concern that the patient has. This study showed that of patients that got enrolled in financial assistance, they saved on average $33,000 annually on medication, $12,000 through enrollment in an insurance plan, $35,000 with insurance premium assistance, and $3,000 with copay assistance. So it's helping patients a lot. So you expect this is going to mitigate financial hardship. We did a study here at Emory again 2-3 years ago. It was a very small study, a pilot study, 12 brain cancer patients. They were receiving the same, the usual care at Emory. They were obviously meeting with the social worker. They were getting everything that was being offered at Emory. But in addition to that, we referred them to Patient Advocate Foundation. It's a nonprofit national financial navigation organization. And you see that despite these patients are receiving all the Emory services, a lot of them have still issues with their insurance, with their cost of living, and a lot of other issues that they also discussed there. And these 12 patients ended up having around $15,000 debt relief as a result of this intervention. So we put together these two things that we talk about. Let's talk about out-of-pocket costs. Let's offer patients financial navigation. And we developed an intervention, what we're calling COSCOM. And during this intervention, the goal was a patient, we're going to tell the patient, first of all, go over their insurance characteristics, tell them, give them some education. What is out-of-pocket cost means? How much is your deductible? What does deductible mean? How much is your maximum out-of-pocket cost? What does that mean? And then how much is your estimated out-of-pocket cost? We use the price estimator tool through a company. And we basically we're getting an estimate of how much patients out-of-pocket cost going to be for their episode of care and telling them that estimate. And then we were offering them financial navigation. Now let's see whether we can enroll you in a better insurance. Let's see what are the financial assistance programs that are available and you can get enrolled in. And we were enrolling them in those. So for this study, we wanted to test it. We started our interventions with MS Clinic because it was easier to recruit patients from our brain health center as opposed to our Winship. So we got a grant from MS National Society. We did a randomized control trial, small study, 62 patients randomized. They received our intervention. Again, everyone was receiving the usual care that was offered at Emory, but our intervention patients were receiving the intervention I described at baseline and then 3 months later. Our study showed that in patients who were receiving the intervention, their financial worry significantly improved at 3 months. While in our usual care group, the financial worry did not improve. It got even worse, but the difference was not significant. And then in terms of the care non-adherence, in our intervention group, the care non-adherence also significantly improved compared to the baseline, but not in the usual care. But again, the study is not a high-power study. So when we took everything in a model, we were adjusting for the baseline financial worry and baseline care non-adherence. The effect of financial worry persisted. We saw a significant improvement in financial worry in patients who were receiving our intervention. The effect of care non-adherence did not persist. And we think that it's probably because our study is underpowered because we saw a significant difference in our intervention patients. So I think like a more high-powered study gonna have a better effect. Following to this study, we got a small grant from ECOG Akron, and we did the same intervention in Ballot Health. Ballot Health is a community oncology practice. It's in Tennessee. It's one of the practices that is associated with SCORE NCORP. And there we offered the intervention only at baseline, and we did looked at the variables pre and post intervention. And this study is still under the analysis, but preliminary result, we saw similar effect. We saw an improvement in financial worry from the before intervention, compared to the post intervention. So which is a good news. And based on these two studies, we actually have an R01 under review. It was scored last cycle 24th percentile. So we hope it gets funded. It's going to be reviewed again in March. So we are offering the intervention to look at comparative effectiveness of the intervention group with the usual care group in cancer patients. These are going to be newly diagnosed cancer patients, and we plan to recruit from ECOG Akron NCORPs. But going back to that financial navigation, a lot of people say that is really financial navigation sustainable? I mean, you need to hire a social worker, you need to hire whatever, a financial navigator, someone needs to talk about these things. And the fact is, it is. That same study from Shankran et al. Showed that the financial navigation, yes, it mitigates financial loss for the patient, but it also mitigates financial loss for the health system. They showed around $2.1 million savings per year as a result of financial navigation. One may ask how. I mean, obviously, if you have patients that are going to be adhered to their medications, they are going to have lower rates of inpatient visits or unexpected ED visits. But in addition to that, if you can just improve financial hardship and you can decrease the care non-adherence, you can have a lower rates of no-shows. And like you're going to have less spots that are going to be empty. This is another study on 244 cancer patients at Cowell Family Cancer Center. They also showed that financial navigators secured $200,000 in health system savings. And this study, the abstract of it was presented at ASCO a couple of years ago, and actually I'm guest editing a special issue in JCR on financial toxicity. So we asked them to actually work on their manuscript, but it was an interesting study. It doesn't focus on financial navigation as a whole. It just looked at the rideshare transportation, which is a part of a financial navigation. And they were offering patients who needed to get radiation therapy, just the people who needed vouchers for Lyft or Uber so that they can come to their appointment. And they showed that an average expected no-show cost, if a patient does not show up for their appointment because they can't afford the transportation, was around $3,800. But if they were offering these patients transportation, annually they needed just to pay around $300, which again shows that this cost of rideshare transportation can be significantly less than the cost of the no-shows. And this is again how the financial navigation can be sustainable for a health system. So what are our take-home messages here? So financial hardship is definitely a health equity issue. And we need to screen for financial hardship. Again, screening was a point that Dr. Kara 2 weeks ago in her talk in the ground round at Winship talked about this. And I think it's a very important topic. Like we should make that as part of our clinic visits. And not just clinic visits, even I'm talking about radiology encounter. We saw how you can identify also patients with financial hardship as radiology. Like we should make it part of the practice at any visit, same way that you ask patients, did you have a fall? Or same way that we have some screening questions at the beginning of health visit. Maybe we should incorporate this as well. And then whoever that fails the screening, refer them for financial navigation. The other thing is that patients are interested in knowing prices. And CMS is advancing price transparency initiative, and their goal was that this is a patient-centric mandate. But there are a lot of challenges. There are a lot of work that needs to be done to make that mandate something that is usable for the patients and benefits the patients. And then financial navigation can save costs for both patient and health system. And actually price transparency with financial navigation might be a solution to mitigate financial hardship. With that, I'm gonna end and take any question. Thank you very much again.
Thank you, Dr. Sadigh. That was a wonderful talk and very enlightening for me, and I'm sure the rest of the viewers. You've had a great turnout this morning. For the audience, if you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, I wanted to mention that next week we will hear from Dr. Lori Pierce, who was last year's ASCO president. She is at the University of Michigan, breast cancer radiation oncologist, and she'll be presenting the intersection of quality and radiation delivery and equity of care. To view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. So Dr. Sadigh, while we're waiting on questions, I was wondering if you could clarify something with the price transparency policies that are in place, is that only applicable to the hospitals or also to the providers who are contractors to the hospital? So like the professional fees for the radiologist, for example.
Yeah, sure. So the current mandate is just for hospitals. So it does not include the professional fees or any contractors. But obviously, despite that, a lot of places are trying to, go through that pathway and like include the I know Emory is in the effort of including the professional fee, just because, it's a patient-centered approach. You don't want a patient receives a second bill and then like complain that your estimate showed something else and I received another bill. And again, a lot of patients are, it's more of a word of mouth. So patients are looking for places that offer this sort of estimator tool. So it's in the benefit of the health systems to include both of them.
Okay, and that's the case also for outpatient clinics as well, or do they fall under the mandate of the hospitals?
So outpatient clinics, if it's affiliated with the hospital, yes, it falls under, if you go to the Emory Price Estimator tool website, they do have for all the outpatient services. Any service that they are offering as an outpatient and it's part of the hospital, they included the price there.
All right, thank you. Dr. Keller asks, it sounds like universal health care would not solve all the issues in financial toxicity. How do you view universal health care?
Yeah, that's a good question and a very challenging question. So, I agree. It's not going to solve all the issues in terms of the financial toxicity because, again, we're still going to have problems with that. But, there are different issues in terms of we know that insurance is going to be one of the problems with the financial hardship. And I don't necessarily, agree that, every, we have that universal healthcare in terms of everyone having the same insurance, but to some degree, again, the effects of it is not very well known. To some degree, it may contribute to some sort of mitigations, but still, our healthcare system problems, it's much far beyond a universal healthcare. Like we have so much problems with our health system, with our billing, with the insurance that, I agree. I don't think that's going to be an issue, but do I have a solution? I don't have a solution for it as well. So
that's a tough question. So, but good answer. So Dr. Jenna Paul Naylor asks, what do you see as the challenges to generalizability of financial navigator assistance programs in different institutions, regions, et cetera?
Yeah, so obviously, not every institution have resources to have a financial navigation for every patient visit or, again, if you think about Emory, and Emory is a good place. If you think about community oncology practices compared to Emory, not everyone have an on-site financial navigators. Financial navigation is only by request from the patients. And there are even some places, some more of a community practices that may even charge for that financial navigation services, which is less than ideal. So I feel like, the issue can be solved by screening for financial hardship. Like not every person may need a financial navigator. I think if you screen for the financial hardship at the beginning of the healthcare visit and you start with those that are at higher risk, that may solve the issue. Because it's far from ideal. I don't think like every place is going to have enough staffing to cover all the patients that are coming. So I think screening can be a good tool for that.
Do you think, as a follow-up to that question, that the financial navigator has to be locally based? Could it be someone who is, mans a region, for example, and knows the insurance coverage and all of the resources there? Do you think
so
there would
not
be a
necessarily
difference?
Yeah, I don't think not. Obviously if you have someone in-house, that's great, because that person can have a one-on-one discussion with the patient, a face-to-face discussion. Sometimes, for a lot of these patients, having that face-to-face discussion is going to help them, especially the people that have lower health literacy, to go over everything. But if you don't have resources, a remote financial navigator can work. Again, the pilot study that we had, both of them, the Ballot Health one and the one that in MS, we use a remote financial navigator. And I feel like for, again, community practices that may not have, or an on-site, you can use a remote, and they are as familiar. Insurance is like we have insurance every state, like everywhere. So they are as familiar with the insurance, a person who might be on site. The only advantage that the on-site person may have is that face-to-face interaction with the patients that can improve that sort of a communication.
Okay. Dr. Loskin asked a challenging question, so I'm sure you'll have a great answer for this. So he says, thank you for a great presentation and for your work in this area. It seems that there are multiple factors involved in cost. For example, as I understand it, survival for prostate cancer is the same whether one has an orchiectomy or takes expensive hormonal therapy, or a modified radical mastectomy versus breast conserving surgery, same outcomes. Physician self-interest may be important in a discussion, and patient preference may be as well. How can you balance all that?
So I agree that, survival outcomes are controversial. There are some studies that show that, higher costs can result in, as you mentioned, are showing that they have the same outcome. But I feel like, if you think about the patient as a whole, as the first part of the question, it's not just the survival. You're talking about the quality of life of that patient. You're talking about the anxiety that patient gonna have because they can't afford. And I think, yes, survival is a great distal endpoint, but you think about that patient that lives those years with what sort of anxiety, how its effect on their caregivers, how its effect on their families. So I think we still have room in terms of improving those parts. And the second part of the question was?
So he's wondering, in the US and other countries, I assume, there are definite financial interest for physicians to propose certain treatments over others, as well as for patients to prefer their preferences based on their value system. So how do you balance those when you're talking about containing financial costs?
Yeah, I think that, to me, when you talk about an informed shared decision-making, traditionally that was a benefit versus risk of the treatment and what your preference is. But I think nowadays with the bills and with the patients receive and the interest that they have, cost should be, a third arm in that discussion. It's not just benefit or risk, it's also what the cost is and how that cost can affect you. Again, there are a lot of controversies in terms of if you ask patients, some patients want to have that discussion right away with the physician. Some patients don't want to talk about this because they don't want their best treatment to be jeopardized by that sort of a communication. But I personally think that as physicians, and again, it's hard, and I'm a radiologist, I don't have patient encounters as you oncologists, and I absolutely, understand that time constraints and the issue of getting costs. But I feel like, as a physician, we must be a little bit of cost aware, know what concerns our patients have a little bit of basic information on the terminology, on how much we expect this medication gonna cost for that patient, and take into the account when we have such sort of discussions with our patients and guide them through, because again, it's not just survival outcomes, it's what patients can experience during that whole episode of treatment and afterwards.
Okay. Last couple of questions, or last question, if anyone has one. Please type it into the Q&A or into the chat. All right. Well, thank you, Dr. Sadigh. That was wonderful. And congratulations on all of the progress you've made in such a short time. It really has been an honor to work with you over the last couple of years. So with that, everyone have a wonderful day. And don't forget about next week's Grand Rounds with Dr. Lori Pierce. Thank you
very much.